Well, hello and good morning. Welcome to another Sunday morning coffee with Dr. Childress here. Um, Today, I'm going to be discussing, obviously, therapy with the attachment pathology that's in the family courts. The first thing to understand about therapy is that diagnosis guides treatment. And so we need to, if we're treating cancer with diabetes or we're treating cancer with insulin, the patient's going to die from the untreated and misdiagnosed cancer. So the treatment for cancer is different than the treatment for diabetes. So we need to know what the diagnosis is that we're treating, and that's critical. If we're treating the wrong diagnosis, nothing's going to happen. Nothing's going to change. So the diagnosis for the pathology in the family courts is child psychological abuse. And that's really, really, really important because if we try to treat child abuse without protecting the child, it's not going to work. Okay, the therapy's not going to work. If I have to, for physical abuse, if I've got a physically abused child and I'm sending that kid home to be beaten with electrical cords, no therapy is going to work. If I've got a sexually abused child and I'm sending that child home to be sexually abused, no treatment for the sex abuse is going to work. Same thing with psychological abuse. If we're sending this child home to a psychologically abusive parent, a parent who has a delusional disorder, a major psychiatric disorder, and they're twisting up the child into all this pathology, and we're trying to get the child to be healthy while that parent's trying to twist up the child, we're just going to rip the child apart. Okay, so we first need to protectively separate the child so that we can recover the child's healthy development. Then we restore with the abusive parent. That's what we do for child abuse. And that's why the child abuse diagnosis is really, really important. So stop using euphemisms for child abuse. It's not parental alienation. It's not resist refuse dynamic. It's not parent child contact problems. Those are all euphemisms that don't exist. Use the real language. Persecutory delusion, factitious disorder, child abuse, and it's that child abuse diagnosis that is critical to the treatment. So the treatment for child abuse by the targeted parent is different than the treatment for psychological child abuse by the allied parent. And so the child is rejecting the targeted parent. The child is seeking to flee from the target. Well, that suggests that targeted parent is abusing the child in some way. And so the treatment for that, if the targeted parent's the problem, is to fix the targeted parent. If, however, it's a delusional disorder and it's psychological abuse by the allied parent, then it's not about the targeted. We can fix the targeted parent till the cows come home. But it's the delusional disorder in the allied parent that's causing the problem. It's child psychological. And so we have to fix the child psychological abuse with the allied parent. So that's a radically different treatment plan as to which parent's abusing the child. So in all these cases, we have to figure out which parent is abusing the child, and one or the other is. If I've got a child seeking to flee from a parent, either the targeted parent's abusing the child, in which case we fix them, or the allied parents psychologically abusing the child, in which case we fix that situation. But just leave it undiagnosed. The child abuse is awful. It's just the worst thing the mental health people can do. They're just colluding with the child abuse if they don't diagnose it. So the question for all parents out there, all the attorneys out there, all the mental health people out there, is what is the diagnosis that's guiding the treatment? So is it a shared persecutory delusion? That's DSM-5 297.1. I need an answer to that. Yes or no? Is it a shared persecutory delusion? Is it a false or factitious attachment pathology being imposed on the child? DSM-5 300.19. And is it child psychological abuse? DSM-5 V995.51. So let me point out, if anybody tells you that's not in the DSM, yes, it is. It's in the DSM. Go look. And we need answers to those questions, yes or no. The court needs answers to those questions because we got child abuse. The court needs to know what's going on, which parent's abusing the child. It's up to the mental health people to conduct a proper assessment and tell us if the allied parent has a major psychiatric disorder, a delusion. Are they delusional, this parent? And then are they producing that delusion in the child? And it's not a schizophrenia type delusion. It's from trauma. Unresolved trauma distorts their thinking and perception, and they begin to see danger where none exists. And so they believe the child is being malevolently treated. No, that's a persecutory delusion in the narcissistic borderline dark personality parent. So we need to get that properly diagnosed. So up on my website over in the attorney section, and I have these both the list, real simple. Okay, what is the differential diagnosis that's involved? So first, is a targeted parent abusing the child in some way and thereby creating the child's authentic attachment pathology towards the targeted parent? If yes, identify the type of child abuse, we'll put it on a treatment plan and we'll fix it. Okay, so that's your first rule out. Child's rejecting the targeted parent. Is the targeted parent abusing the child? And if so, how? If not, then it's a false or factitious attachment pathology. And now we're into the second differential diagnosis, which is the allied parent psychologically abusing the child by creating the shared persecutory delusion and false or factitious attachment pathology for primary and secondary gain to the parent. So there's your differential diagnosis right there. Now you can get a little bit more specific on it. And so you can say, does the allied parent have a persecutory delusion? Yes, no. We need an answer to that, please, from the mental health people. Yes, no. And if they're not capable of diagnosing it, then they need to refer to somebody who is, because we need an answer to that question. The court does, the treatment plan does, everybody needs an answer. Is the allied parent have a persecutory delusion? Are they imposing that on the child? Second, is this a factitious? Does the child have a false or factitious attachment pathology imposed on the child by the pathogenic parenting of the allied parent? Pathogenic, pathology creating. So is it a false, factitious attachment pathology? And is it spousal psychological abuse of the targeted parent by the allied parent using the child as a weapon? We have two potential abuse diagnoses: child abuse by the targeted parent or by the allied parent. So we need to get a proper risk assessment for child abuse. And we got possible spousal abuse of the targeted parent by the allied parent using the child as a weapon. So we got two duty to protect. We got two abuse pathologies. We need an answer to that question for treatment, for protection, for the court's custody decision making. And so the mental health people, that's their obligation. That's what they're trained to do. That's their job. That's what they're supposed to be doing. But they're not. And so that's really becomes a significant problem in the mental health sector. The treatment for child abuse. Now, we're just talking today about therapy. So the treatment for child abuse is to protect the child. Okay, so that's, again, foundational to understand. That's why it's important to have the diagnosis, because the diagnosis guides the treatment. If it's child abuse, we protect the child. So for all forms of child abuse, all forms, physical, sexual, neglect, psychological, the treatment for child abuse is a protective separation from the abusive parent. We then restore the normal range and healthy development of the child. And then we reunite the child with the abusive parent with enough safeguards in place to ensure the child abuse does not resume when contact with the abusive parent is restored. So we we protect the child, we recover the child's healthy relationship with the targeted parent, then we restore with the allied parent, and then we put on safeguards to make sure the abuse doesn't happen again. What are those safeguards that we put on? Supervision, not for psychological abuse. If we put on a barrier like supervised parenting for psychological abuse, that parent just goes right around it. It's a communication thing. So it's now what we do is outcome measures, and we adjust to things based on outcome measures. So I'll talk about that in a second. The outcome measures, symptom monitoring, is what the safeguards entail. So the pathology in the family courts is child abuse. So it's either the targeted parent is abusing the child in some way, resulting in the child's rejection of that parent, or the allied parent is psychologically abusing the child by inducing a shared persecutory delusion and false factitious attachment pathology in the child, DSM-5 diagnoses. So we must first protect the child. We cannot ask the child to reveal their authenticity and bond to the beloved targeted parent until we can first protect the child from the psychological retaliation that is sure to follow if the child bonds to the targeted parent. Important to understand, if we're trying to get that child to bond to the targeted parent without protecting them from the retaliation, we're sending them home to be with that pathological allied parent. If they do bond to that parent, the targeted parent, the psychological retaliation from the allied parent is going to be severe. When they have that child, they're going to go into a dark mood. They're going to manipulate, guilt trip, all sorts of things on that child, loyalty bonds. So that child, unless we can protect the child has to survive with a pathological parent, narcissistic, borderline, dark personality parent, highly manipulative. And so we need the diagnosis so that we can then move into protecting the child, and we get clarity on things, clarity on what the court's decision making is, clarity on the diagnosis, clarity on the treatment plan, and clarity for the child, which is critical for the treatment. So if we have a misdiagnosis, there will be failed treatment. Fact. If we are treating cancer with insulin, the patient's going to die from the misdiagnosed cancer. So no treatment for child abuse will be effective when the child is left in the care of the abusive parent. Okay, that's just so foundational to working with child abuse, and that's what we're working with is child abuse, and that's why we need to say the word child abuse, because it's important for our treatment. If we don't say that, then we're misdiagnosing the child abuse, and we're not going to get effective treatment for the child abuse, which means protecting the child. We're not going to protect the child, and the child is going to be abused. I mean, it is so incredibly simple for the mental health people. So incredibly simple. Yes, no, here's a diagnosis. Which parent's abusing the child? They refuse to diagnose. They refuse. They just say, no, I'm not going to diagnose with the child abuse. Well, guess what? Then you're going to have hundreds of thousands of children in the family courts who are being abused because the mental health people are not protecting them. They're not diagnosing the child abuse and treating it. And so we have families destroyed, the lives of children destroyed, hundreds of thousands of children over 40 years. It's just been a nightmare in the family courts because they refuse to diagnose the child abuse. The psychologists do. It drives me crazy. So if the opinion, here's the statement to the child. And this statement is what, as a psychologist, we need to be able to make to this child. This is my recommendation. So once we get the protective separation, I would tell this to the child. It is the opinion of the treatment team in the court that your mom or dad is leading the family in a bad direction and that a child protection response is necessary. Okay, so notice how I frame it. I'm not framing it as they have a significant pathology. I might, but I'm less likely to do that. I'm going to frame it in a way that seeks solutions. And so the allied parent, the mom or the dad, the allied parent, is leading the family in a bad direction. Okay, and they're going to lead it into a cutoff family structure. And that is the opinion of the authorities, the treatment team in the court, that we need to protect you. Now, the child may say, no, they're great. And we say, well, no, that's our opinion of the professionals here. And that's important to communicate to the child, that the parenting of the allied parent is sufficiently distorted that we need to protect the child from that parenting. That helps the child orient to where reality is. And we're treating a delusional disorder. Diagnosis guides treatment. It's a delusion. The child has a delusion. You do not agree with the delusion. You challenge it. You say, no, that's a false belief. It is the treatment team and the court's decision that targeted parents, totally normal range. We need to establish with that. Now, following that statement, the next statement is, the court has therefore placed your dad or mom in a leadership of this family. So we place the targeted parent in leadership of this family to restore a healthy separated family of shared bonds of affection with both parents following the divorce. So you see, we say the allied parent's problematic. They're leading this family in a bad direction. They're having a negative influence on you that's problematic. Then we say we're placing the targeted parent, your mom or your dad, in a leadership position in this family. They're going to be the one leading this family into a healthy, separated family after the divorce. So we're reorienting the child around to reality. Then following that, the next statement is, the court and the treatment team are asking for your cooperation with your targeted parent, with your dad or mom, in restoring a healthy and normal range family for you and for your siblings, if there's siblings involved. And so you can see the three parts of that. We orient the child to where it's a child protection response, and that's our judgment that the allied parent is significantly problematic in their parenting leadership. Then we reorient to reality and say the targeted parent's fine. They're going to be leading that. We give them support for their authority in the family and stop the inverted hierarchy. We put them back on top in the leadership position of the family, and we give them our support as a treatment team for their leadership. Again, reorienting the child. Targeted parents normal, allied parents not. Then we say we would like your cooperation with the targeted parent in leading this family. And that's the first step of getting that rebond again, back into the loyalty to the treatment team. The court's asking for their cooperation. All the authority figures are asking for the child's cooperation with the targeted parent's leadership. So that's the statement that we need to be able to make, and we cannot make that until we get the child abuse diagnosis, protect the child, then boom, 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 we reorient the child to reality, and we can begin to do the therapy. Now, the other thing I'm very likely to explain to the child is that the nature of what's going on, that there's two transitions after a divorce. And I would explain that, divorce is not a bad thing. It's not a horrible thing. It happens all the time. It's unfortunate, but it happens all the time. And then a lot of families get through it just fine. So what we're doing, or what's happening, is the family is merely transitioning from its prior intact family structure where the child can kind of float around and it's united by the marriage. It's transitioning from an intact family structure. The parents can't get along, so now it's become a separated family structure where the parents are living in different houses, but we're still united by the child. And so that's a healthy separated family structure. That's what we want to get on the top. What we want to avoid is when the parents get too much conflict and they rip the family apart. Now you have a pathological cutoff family structure where the child has to choose sides. That's the pathology in the family courts, is a pathological cutoff family structure. And so what we want to do is get this back into a healthy family structure. So I would explain that to the child, that we're just going from this and parents can't get along, but we got this as normal. We want to avoid this. And then your allied parent, the mom or dad, who's ever the allied parent, pathological one, is leading this in a problematic direction. They're leading this into a cutoff family where they have to choose one side or the other. You're rejecting your, dad, and so mom's leadership is problematic. So what we're doing is replacing your targeted parent, your dad or mom, who's ever the targeted parent. We're going to put them in leadership because they can lead this family into a healthy, separated family. Okay, so those are your first two statements. Allied parents leading it into a cutoff, targeted parents going to lead it into healthy. We're asking for your cooperation to work with your targeted parent, mom or dad, and lead this family into this. So we're getting a combined treatment goal for what we're looking for is a child bonds to both parents. And they say, oh no, my mom is great and I love her and she's not abusive and everything's fine. And we say, yeah, but her leadership has taken it this direction. So because look, you're projecting one of the other parent. And so just get us back to this place and then everything goes back to normal. So you say, oh, I love my pathological mom or dad. That's fine. That's fine. We love. Good. Okay. We don't mind that. What we want to avoid is that cutoff, because that's not healthy for you as a young person. The courts decided that. Your treatment teams decided that. So what we're going to do, and this is the next step that I would explain to the child as the therapist. And so what we're going to do is we're going to get some outcome measures. And so this is true for treatment of anything. It's true for the treatment of medical disorders. If you have a medical disorder, they do blood tests and they say, you got a problem. They give you the medication. 6 weeks later, you come back, you get another blood test to see if it worked, the outcome measure. All treatments should have some sort of outcome measure to monitor progress and goal accomplishment. In this case, I recommend that the targeted parent should provide to the family therapist, just email the family therapist, 3 numbers every day, daily ratings for 3 items using a 7-point scale. 1 or 2 are bad, 6 and 7 are wonderful, 3, 4, 5 is normal range. On affection, cooperation, social involvement. 3 numbers: affection, cooperation, social involvement. Targeted parent rates those 3 numbers every day, sends it to the family therapist. So now if I'm the family therapist explaining this to the child, I say, so as long as you stay 3 or higher, 3, 4, 5 or higher than normal, then we got a successful separated family where you're bonding into, you don't have to be 6 or 7, just normal. Okay, just a normal family. But if you're 1s and 2s, that means we have the cutoff family. And so that's what we're going to be responding to. If we have a cutoff family, then we're going to say your allied parent, mom or dad, is leading the family improperly because, look, it's getting this situation. Okay, so what we're asking for is your cooperation to just be normal range, 3 or higher. Social skills, be polite, say please, thank you, and just bring it down, bring down the level of intensity, the level of fighting, level of everything, so that we can just get you a normal life where you're just, focused on school and sports and friends and whatever it is that your child life involves. but get you out of the family conflict. So that's what we're going to do. Now, I don't care if the child drops 1 and 2 every now and then. That's normal too. But if they stay down at 1s and 2s, that's the influence of the allied parent. And that's, again, why we need the diagnosis. Because if the child drops to 1s and 2s, do we go, oh, the targeted parent is doing things again, and we start chasing the false disorder? When we get the diagnosis of the delusional disorder and the psychological abuse, then the child drops in 1s to 2s. I'm attributing it to the allied parent. That they say, oh, my targeted parent was yelled at me or something. They say, no, that's normal range. You were mouthing off or whatever. We'll look at it. We'll talk about it. But we'll say, no, it's the influence of the allied parent. And they're going to do it. They're so manipulative. Narcissistic borderline parent, we can't follow them around and find how they do it. We'll just watch the outcome. If the child's normal range, there's no child abuse. If the child drops to 1s and 2s, there's child abuse. That's how we add the safeguards on the restoration. We get the protective separation. We get the child back up into 3s, 4s, and 5s on the affection, cooperation, social involvement. We say, great kid, you're doing great. You're giving us normal range off of this. And so now we're going to restore contact with the allied parent. Just stay normal. Just keep doing what you're doing. Stay normal range, and then everything's going to be okay. The other thing I will tell typically older children too is I will say, I'm going to be watching your responses here and your world, and I'm going to be using that. You're going to be able to communicate to me what's going on with the allied parent. Okay, with your mom or dad over there, without having to throw them under the bus. Okay, so if you stay normal range, 3 or higher with the targeted parent, that's communicating to me as your therapist that whatever's going on with the allied parent, you're handling it well. You're handling it okay because you're staying normal. There's no child abuse if you're in the normal range. So, okay, that's fine. Everything's good. If, however, you get over there and it's too intense for you and you have to collapse into them, then you're going to start being 1s and 2s with the targeted parent, and that's going to communicate to me that you had to collapse into whatever they're doing, and there's child abuse has started again. So then we have to take a protection from you. And so that's going to have longer range consequences of taking away the motivation of the allied parent to produce the pathology. Because right now they're getting rewarded for that. If they produce pathology in the kid, they get the kid. But now once we get the diagnosis of child abuse, if they make the child pathological, the targeted parent gets more time with the kid and they get less time and they're labeled an abusive parent. Well, that's not working. That's not what they want to have happen. For them to be the abusive parent, for them to get less time, they want a spouse abuse of the targeted parent and stuff. And so the moment we take away their motivation, the rewards for that, the function the behavior serves, functional behavioral analysis, the moment we take away the function of the behavior, then they stop trying to produce it and they release the child because it's no longer working for them. Functional behavioral analysis make the behavior ineffective or inefficient in doing the function. So outcome ratings, simple, 3 items. The other feature about the outcome ratings is it restores, we have an inverted hierarchy in the family where the child is judging the targeted parent as if the parent were the child and the child were the parent. Inverted hierarchy. Well, this reestablishes a proper hierarchy where the parent is judging the child as appropriate in affection, cooperation, social involvement. And then every week you send it to the family therapist. Every week you go to the family therapist. The family therapist has all these ratings on an Excel file. They already know. They come in and say, oh, look, you got a 2 on Tuesday. Tell me what happened on Tuesday. And then he gets the information from the child, from the parent about what happened on Tuesday, walk it through step by step. Applied behavioral analysis. What were you thinking, feeling, and doing in that situation? And you go back and forth between the two of them and you figure out what's going on in that situation. Was it a 2 or maybe a 3 or maybe a 1? And that's the therapy, is you're talking with the therapist about what's normal range. If there's a problem with the parenting, you get on it and say, well, no, I think that was a little problematic. Here's how we can adjust that. If it was a problem with the child, we say, no, that's normal range parenting, and here's how we expect normal range kids to handle the situation. Okay, so that also becomes the focus of the treatment. That prevents us from going to that, unforgivable grudge. Well, 2 years ago you did something, and well, what? And so I don't want to. No. Let's get to the current situation. Let's get solution focused. Let's get outcome measures, and then we can guide that. We can also monitor whether there's child abuse going on. Outcome measures. So if you're a parent out there and you got inadequate therapy, or you got something, child individual therapy, or some sort of thing that's not working, I just recommend you just start doing these ratings when you're with the child and emailing the 3 numbers to the therapist. And they say, well, what am I going to do with them? I say, they're an outcome measure. You should have an outcome measure. I don't know. I want my relationship normal range, and it's not normal range. So what's the treatment plan to get normal range? And how long is it going to take to get normal range? And let's get moving on this. It's a treatment plan. You can Google treatment plan, WikiHow. WikiHow mental health treatment plans comes up and tells you goals, interventions, timeframes, and outcome measures. Ask an AI about treatment plan, mental health treatment plans, and outcome measures and stuff, and get the AI to help guide you through the process. It's standard psychology. It's standard healthcare that I'm talking about here. So we're going back to the idea of treating child abuse. We protect the child. We recover the normal range, healthy development of the child. Then we restore with the abusive parent with enough safeguards in place. Well, the safeguard is the symptom monitoring. So damaged affection, non-cooperation, and social isolation from the targeted parent are the symptoms of child psychological abuse. So if we see those, the child's being abused. If we don't see those, the child's not being abused. And so I'm not chasing the bad parenting of the pathological allied parent. I'm watching the child's symptoms and making a decision as to whether there's child psychological abuse. I have to first vet the targeted parent and be reassured the targeted parent's normal range. So that's my rule out diagnosis. I talk to everybody and say, is this authentic abuse by the targeted parent? No. Well, then it's a factitious disorder. We got a delusional disorder. So now, if I see symptoms, it's being caused by the allied parent. So as long as the child is normal range, 3 or higher on affection, cooperation, social involvement, a diagnosis of child abuse, psychological abuse, is not warranted. So that also then leads into potentially a contingent visitation schedule. And this is a little booklet. You can get the booklet on Amazon. Okay, contingent visitation schedule. You see it right there on the video screen. In 2024, I presented on this at the American Psychological Association on how to run a contingent visitation schedule. Then I came home, did the exact same presentation on YouTube. So you have it up on YouTube. The contingent visitation schedule, you have a book. It involves monitoring those outcome measures. And then if the child becomes symptomatic, the time with the allied parent drops. If the child is normal range, then things go back to the court-ordered schedule. And so it's contingent upon whether child's normal range. And so it's a classic sort of, it looks like a behavioral program. It's actually strategic family systems. It's taken away the motivation for that parent to produce the pathology in the child. So you have a video up, you can watch that. You have a booklet you can give it to the court, you can give it to the therapist, you can give it to everybody, your attorneys and everybody. Now, in addition, I have a whole diagnosis series. And so this particular one is diagnosing attachment pathology. I really recommend people watch this one because this is about the factitious disorder, and this describes how anytime a child is rejecting a parent, there is child abuse. I just don't know which parent yet. Most often, if a child's rejecting a parent, that would suggest child abuse by the targeted parent who's being rejected. But if it's not true, then I'm looking at a delusional disorder in the allied parent in the context of the divorce and manipulating the child and false factitious attachment pathology. I also have video segments on diagnosing a delusional disorder, on diagnosing a factitious disorder, on the DSM-5 diagnoses, on how to assess for parenting. So I've got all the diagnostic seminars up on YouTube. Any mental health professional, any one of them, can go to YouTube and watch how to do this and learn how to do this. They're just too lazy to know what to do. They don't care. Then because there's no enforcement of ethical standards, it's just such a mess in the family courts. So, but it's there. You can watch it. You can become an informed consumer. I recommend you do. It's your child. So you're going to have to learn how to do psychology and how to do treatment and how to do diagnosis, because you're going to have to explain it to the doctors. You know how bad it is when the patient is explaining the pathology to the doctors? Imagine going in for like cancer and you're having to explain what cancer is and how to assess for it to the doctor. No, they should know what is going on. That's their job. And so it's so bad in the family courts. So recognize how bad it is, and it's going to take, I think, a class action lawsuit. Okay, I think it's institutional betrayal, regulatory capture, and it's just a nightmare. They're financially exploiting you. They're violation of multiple ethical standards, a whole bunch of stuff. Legislative oversight of the licensing boards would be helpful as well. So that's there. I also have up on my website clinical case vignettes. So, Smith family, where we have a targeted mother, a lied father. So that's going to be a narcissistic dad pattern. And we got 3 children. 12-year-old is most likely the one that's targeted child, the allied child, and the 2 are 9 and 7-year-olds are kind of following after. Typically, it targets the eldest child in the situation. So I have a video that talks about that particular pattern. And I have 2 on the narcissistic dad pattern. I have 2 on the borderline mom pattern. So you can go, and your therapist can go and watch the vignettes and say, oh, that applies, that applies, that applies, that applies. And so I've given you the treatment, contingent visitation schedule. I've given you the diagnosis, how to diagnose it. I've given you case vignettes. So I don't know what more I can provide to your mental health people. Okay. And I'm available. They can get a hold of me. I can do consultations with them and help them figure that out. I'll be starting a consultation group where mental health people can join up, and we can talk about their cases and get accurate diagnoses and start protecting the children. But it takes motivation from the therapists to be competent and to know what they're doing and protect the child. If there's no motivation, if they don't care, then the child's going to be abused. And they're going to take your money and financial exploitation. The court's going to make bad decisions. That's just reality. Whether it's in healthcare or in medical issues, or whether it's in psychological issues. So now here's for your mental health people: withholding the child abuse diagnosis covers up the child abuse. So this is important to understand as well. When the mental health people have a responsibility, when they're the forensic psychologist, forensic custody evaluation, when they get a referral and they're on the court list and they're going to assess for the family, if they don't tell the court when there's child abuse, then they're failing the court. They are withholding information from the court that the court needs in its decision making, and they're withholding that information from one of the litigant parents, the targeted parent, and their attorney. And if they had the child abuse diagnosis, a delusional disorder diagnosis, they could then advocate with the court for a child protection response. But they can't do that because you're withholding the diagnosis from them. That favors the pathological parent who's abusing the child. You're covering up their child abuse by not identifying it. And so I need to know, yes or no. If it's not there, if they're not abusing the child, if they're a live parent, then say no. There's no delusional disorder. Thank you. Did you assess for it? How did you assess for it? But thank you. No, it's no child psychological abuse. Well, then it's abuse by the targeted parent. If it's got to be one or the other, okay, because the child's rejecting a parent. So what is the abuse by the targeted parent then? We'll put it on a treatment plan. But it's got to be one or the other. And that's what we get clarity on. Yes or no. Yes or no. Did you assess for things? And the court deserves that information. The litigant parents deserve that information. They need that information. And so by withholding the diagnosis and not telling people, the psychologists and other mental health people involved are covering up the child abuse. And so if they use other euphemisms, parental alienation, resist, refuse, parent-child contact problems, they are covering up the child abuse. We need answers, yes or no, on that sheet of paper. They can call it, weird affection syndrome if they want. Okay, I don't care if you make up new, but let's stay in the DSM and get a real diagnosis, and then you can add whatever you want, and that's fine. But is it psychological child abuse? Yes or no? That guides treatment. Court needs to know. Everybody needs to know. And it's spousal abuse, psychological abuse of the targeted parent. The pathology in the family courts is spousal psychological abuse of the targeted parent using the child as a weapon. There's your DSM-5 diagnosis, 995.82, spouse or partner abuse, psychological. So if anyone tells you, oh, this isn't about you, it's about the child, that's a lie. It's totally about you. This is spousal abuse using the child as the weapon. And in weaponizing the child, they create such a degree of pathology, it becomes psychological child abuse. But at its core, this is spousal abuse using the child as a weapon. So the mental health people should also be protecting you, the targeted parent, from this emotional and spousal abuse. Oh my God, it's just devastating. You lose your child, the grief goes off the chart, you're being investigated as being abusive, you're dealing with a delusional disorder. The mental health people need to figure this out. And because the mental health people work in the family courts all the time, we should know this coming in. You parents are coming in, you had a normal family. You didn't know everything was this bad until you get the divorce, and then it starts to spin out of control, and you're going, what's going on? My child has become a different person. There's false allegations, and so you're very disoriented by the situation. But all the mental health people should be totally oriented. Okay, that's a delusional disorder, or okay, we got a child abused by the targeted parent, or so the mental health people should have a handle on it. You shouldn't have to be educating them. They should have already watched all the videos on how to diagnose and all the vignette videos, and they should know about the outcome measures and explain it to you. That's their job. Oh, they're so bad. It is so bad. So if anybody tells you this isn't about you, that's a lie. Children love their parents. That's just a fact. The child loves you. Of course they do. Your mom or your dad. So I will in the future talk a little bit more about that, because that's an important part of getting you into that leadership position. Is you can't be chasing the lies. Okay, but right now the lies you're trying to convince everybody, the mental health people, the court, everybody, it's not me, it's not me, it's a lie, it's a lie, it's a lie. once the mental health people get competent, we go, no, I got it. We do proper assessment. We go, don't worry, we see where it is. And then we're going to put you in the leadership position to lead, and then we need you to step up into that leadership position. Be a wonderful parent. That's going to be the first bullet point in the treatment plan is a wonderful mom or a wonderful dad bullet point. We are going to make the targeted parent wonderful because that's a good thing to do all the time. And that takes away all the, oh, you're a bad parent because, you didn't take me to McDonald's kind of stuff. No, you're going to be a wonderful, wonderful parent. And I'll talk about that later. But that's the first bullet point on all the treatment plans. Tell the child, tell the allied parent, we're going to do, look, you got a problem with that parent. We're going to make them wonderful. And that's also called a response to intervention. If we make a wonderful mom or wonderful dad, the targeted parent, and the child's still rejecting that parent, then that parent's not causing the problem. It's the allied parent because the targeted parent's wonderful. That's the treatment. And if anyone, including the child, tells you the child doesn't love you, that's a lie. It's a pathology of lies. Don't go chasing that sort of stuff. But again, I understand why, because you're trying to anchor in reality, and right now the mental health people are absolutely awful. So now here's important to understand for all the mental health people. If the involved mental health professionals believe a shared delusion as if it was true, then they become part of the shared delusion. They become part of the pathology. And when the pathology is child abuse, they become part of the child abuse. The mental health professional becomes part of the child abuse by validating to the child that the induced persecutory delusion is true. Okay, so that's the nature of this particular shared pathology. It's dangerous because if you believe the shared delusion, you become part of the child abuse. And when the pathology is also the spousal psychological abuse of the targeted parent, the mental health professional becomes part of the spousal abuse because of their misdiagnosis. So that is extraordinarily problematic when the mental health people are child abusers and spousal abusers because they misdiagnosed the pathology. And the reason they misdiagnosed it is because they're practicing beyond the boundaries of their competence. They didn't conduct a proper assessment for the differential diagnosis. So they wind up getting caught up from their own countertransfer and stuff. They get caught up in the delusion. They want to be the protective other, and they join that alliance with the allied parent and the cross-generational coalition, and they become part of the child psychological abuse and a part of the spousal abuse because of their misdiagnosis. So it's so bad in the family courts. And so all you parents coming into family courts, you say, what can I do? Until you correct the low level of professional services in the family courts, it's just going to chew you up. You need a diagnosis. What do you do? What do you do? How do you solve this? What's your diagnosis? And tell me the diagnosis, I'll tell you the treatment plan for everything. So what's the diagnosis? Is it a shared delusion? Well, I can't get that diagnosis. Well, then that's your problem. You need to get that diagnosis. And then you're going to run into the multiple problems. And you can give them my videos and stuff and see if you can solve their ignorance. The court-involved mental health professionals are colluding participants in child abuse and spousal abuse of the targeted parent because of their negligently incompetent misdiagnosis. That's the truth. Okay, so it's just really, really bad in the family courts, and they don't care. Nobody cares. So in the assessment for child abuse, in all cases of court-involved custody conflict involving severe attachment pathology displayed by the child, a child rejecting a parent, a proper risk assessment for child abuse needs to be conducted to the appropriate differential diagnosis for each parent. All cases, all cases. That should happen, boom, immediately. The moment it comes in, the court says, oh, I got a child rejecting a parent. Let's get it out to mental health assessment. 6 to 8 weeks, we can do a clinical diagnostic assessment of the family for child abuse, which parent's abusing the child, get that back into the court. If the court needs a custody evaluation, then it can order that later. If the court needs advice on the court doesn't need advice on custody. The court needs advice on which parent's abusing the child. So let's get it out. It's 4 to 6 weeks, $5,000 maybe even less. Okay, and so we can do this. Absolutely, we can do this as soon as there's a motivation. Problem is, there's no mental health professionals who are doing diagnostic assessments for the court. They're only giving custody evaluations. That's the only thing they offer. $20,000 to $40,000, 6 to 9 months to complete when it's possible child abuse, and they don't diagnose the pathology. Custody evaluations need to stop. Stop them. Stop. They're bad, dangerous, harmful to children. New York Blue Ribbon Commission, lack scientific and legal value. Stop them. What's the diagnosis? Then we treat it, and then we fix it. And the child has a normal range life within 3 to 6 months, and everything's fixed, rather than years of destroyed lives and years of conflict. So everyone else in all of healthcare, okay, gets diagnosis and treatment. ADHD, autism, eating disorders, cancer, diabetes, whatever it is, everyone else gets diagnosis and treatment. You in the family courts don't. You get forensic custody evaluations that withhold the child abuse diagnosis and collude with the child abuse by not telling the targeted parent and their attorney and not telling the court about the psychological child abuse of the child. They're putting their finger on the scale and withholding relevant information about child abuse. So, and about spousal abuse. They're withholding the information that the targeted parent is a victim of spousal abuse in this situation by not conducting the proper assessment and diagnosing the spousal abuse. So the pathology in the family courts is psychological child abuse. The pathology in the family courts is the spousal psychological abuse of the targeted parent using the child as the weapon. And that's the truth. Okay, so diagnosis guides treatment. Once we have an accurate diagnosis, we can fix anything. So go back to that sheet, yes or no. Tell me what the diagnosis is, and then we can fix it. And so I would suggest you just start handing that out like candy to every mental health professional. Please answer these little simple questions. If they cannot answer the question, that means they are practicing beyond the boundaries of their competence. So they need to refer to somebody who is, or they need to consult with somebody so they can answer those questions. There's a reason we have the DSM-5. There's a reason why there's 4 child abuse diagnoses. So therapy, treatment, diagnosis guides treatment. So with that, I'm going to head off to my Sunday here and talk about some other aspect of the family courts next Sunday. Take care, everybody.